Diabetic macular edema management. Well, diabetic has become a real threat, and it has become an epidemic for all across the world, and not leaving behind our own country, where we will be having more than 70 million diabetics to treat in coming years. So it's very apt for us to discuss about this particular diabetic retinopathy and diabetic macular edema, that the ways how we can treat. It was an era when we started treating only when we had lasers, we went gaga over it. But at that time, we thought about only stabilizing the further visual loss. With the advent of pharmacotherapy, we had so much of potentials. We started speaking for the first time to the patient, console them that yes, we can retain your vision and sometimes improvise. And now there is a flood of newer molecules which are coming and making this treatment more affordable, more palatable, in the way that it is becoming more durable, thereby reducing the burden on the treatment, on the patient, of the treatment for the patients. So without much ado, let's begin this dialogue on diabetic macular edema. It is my privilege to have panelists Dr. Mudit Tyagi and Mangat Dogra, sir. Welcome, sir. And we'll begin with the very first talk on and also Dr. Toshinora Murata. Welcome, sir, for this particular discussion. So can I request Dr. Devendra Venkatramani to begin his first talk on dilemmas in treatment with recalcitrant cases, when to switch.
Hello. Very good morning to everyone. I'm very happy to be part of this session, and thanks to the organizers for the same. As Dr. Bhavankure sir described the problem statement, it's really a big problem, and we have to bear in mind that it's not only the size of the problem, but also the magnitude or the extent to which it can affect vision. And diabetic macular edema is the leading cause of visual impairment in a diabetic patient, and it predominantly affects younger patients and those at their prime of economic life. And you can see that also the type of diabetes plays a role. But while the treatment of diabetic macular edema has evolved over the last few decades, there are still patients who don't respond optimally or as we would have really liked them to. And these are some analysis from the protocol I of the DRCR network. And you can see at various time points, whether it's the first year, 81%, at the end of 2 years, 56%, and at the end of 3 years, almost 40% of patients who still require ongoing treatment. So it's a very ongoing problem, not one with a quick fix as many would like. And a lot of literature supports this idea that persistence of the macular edema results in lower visual acuity gains. And that's obviously intuitive when we look at our patients as well, that those who require multiple injections over a period of time keep losing vision gradually, or they don't improve as those who responded well initially do. And here you can also see how the central retinal thickness has correlated with poorer visual recovery in eyes, where the central retinal thickness continues to be in the higher quartiles. So in the past, we've always been treating now diabetic macular edema as an anti-VEGF treated problem, but steroids do have a role as a second line agent, and there are certain specific areas where one could still prefer steroids. In those, we can consider non-responders, in somebody who has a major cardiovascular event in the previous past, in the recent past, or in chronic patients with pseudophakia. But looking at the visual acuity gains with steroids, and this is data that is now available, and the Maggiore study was the only one that looked at head-to-head data of ranibizumab versus Ozurdex implant, and you can see that the visual acuity gains, unfortunately, with steroids are not as much as they are with anti-VEGF. And here you can see that the anti-VEGF gains have been blunted by the ceiling effect, because they almost, in many studies, they reached the plateau of 70 letters. And we've been practicing this as a strategy for many years, that if a patient does not respond with one therapy, you can switch over. But studies do show that switching over may not ultimately yield a better visual outcome. And these are, comparisons of switching switching over to a dexamethasone implant or that in combination with anti-VEGF, and there does not seem to be significantly better visual outcome. So we need not even then go into the adverse event profile of steroids. Now, it's not been too long ago that Kite and Kestrel came out with their data on brolucizumab in diabetic macular edema, and you can see the extremely salutary response it had on the central subfield thickness. And of course, it was being compared to the standard of care aflibercept 2 milligrams. And these are the CSFT data persisting into the second year. And the visual acuity gains as well, which were comparable to aflibercept. I think this is well established, but sometimes as clinicians, what we tend to overlook is the number of injections that were required to produce this effect. And in the first year and in the second year, you can see a significantly less number of median number of injections. 7 of brolucizumab versus 9 of aflibercept, and at the end of the second year, 11 versus 15. So that, I think, is a significant factor. And similarly, the drying ability or the durability of the injections was appeared to be much better with brolucizumab, with a fewer number of injections compared to aflibercept. So this is some of the post hoc analysis as well, and you can see that the area under the curve are different for brolucizumab and aflibercept, and significantly so. So the drying ability of the molecule seems to be established against the current gold standard, or what we would have called the standard of care a few years ago. So, with that background, I just thought it would be pertinent to look at some cases that we've had during our treatment of patients with diabetic macular edema with brolucizumab. And I'll very quickly take you through a patient who has been with us for more than 5 or 6 years, and he had already received aflibercept biosimilars in the past. And this was the picture when he presented to us in 2018, and we decided to switch over to a steroid principally for the longevity of effect. And both eyes received dexamethasone implants, and they had a good result, but the patient continued to require intermittent dexamethasone implant treatment almost on a 3-monthly basis. And here you can see over the years 2019, and here you can see in the OCT that there is some media opacity developing, and continued treatment with dexamethasone, worsening of the media opacity, so to the extent that you can't even get the normative values of the OCT. He underwent phacoemulsification when his vision had really dropped to a terrible level, but he regained some vision, and now you can see chronicity in the OCT, which means that these unfavorable biomarkers, prognostic biomarkers like drill or disorganization of the retinal inner layers, and the skytic nature of the fluid as it has now evolved over the last few years, 4 to 5 years, means that the visual acuity is not getting back to what it used to. So one eye seems to be maintaining vision while the other is continuing to lose vision, and there are these multiple retreatments required. So it was in July last year that we decided now to switch him over to brolucizumab, because he was losing the effect or the advantage of dexamethasone within 3 months. So, that is something that we then really need to think about doing something different. So you can see that with brolucizumab over a 1.5-month period, very good drying, still some recurrence after 4 months, and then repeat injections are going to be required. But the moral, I think, out of this case is that the visual acuity improvements now, if you look at the left eye, although the macula is very dry, the visual acuity has gradually declined to a level that it's not being able to be restored because of foveal atrophy and loss of the retinal architecture. So this is a very a contrasting case where we had this patient who had diabetic retinopathy and maybe a component of very microvascular occlusion over there, and extremely poor vision. And with a single injection of brolucizumab, she improved very well, and she continued to improve, and this is the last follow-up with a very sustained benefit. So I'll summarize all of this, literature as well as this real-world experience into, these few points that while anti-VEGF does appear to be the mainstay of treatment in diabetic macular edema, we have to bear in mind that persistent edema over many months and years will equate with a poorer visual outcome in the long run. And while we are tempted to start initial treatment with different molecules, and while optimizing treatment may involve switching over to different molecules during the course of the patient's treatment, switching late may jeopardize the visual outcomes because by the time that anatomical changes have set in into the retina, it may just be too late. I think a very important take home is that every intervention that we can reduce is a saving, not only in economic terms, but also in terms of potential side effects and complications for the patient. So if over a span of a year or 2 years or 5 years of treatment, if we are able to achieve favorable results with fewer interventions, I think all of us would prefer that for our patients. I end my talk here, and it'll be a very interesting discussion, I'm sure.
Thank you. Thank you, Dr. Devendra, for highlighting the importance of this newer molecule in the treatment of such recalcitrant cases. In fact, the second case, if we ponder upon, was it a case of a diabetic macular edema versus a type of a occlusion? And do you mean that even in occlusion cases, it does respond that favorably? Also comment from sir.
Well, I think I do have some rare experience. It works very well for occlusion cases also. But what is important here is what he highlighted. I think once we get late, I think, and we keep on switching and we should not allow it to come back. Interretinal fluid, that is where the bottom line is. If we are allowing it repeatedly to come, it is going to damage. It is ultimately going to lead to this. That is why we always emphasize that strategy of treat and extend, and somehow having a protocol where we can prevent that. You will not have from 6/9 coming to almost 6/24. So that is very, very important.
The other point is that often what we are only looking at sometimes are the improvement in terms of visual acuity, but now there is more and more evidence emerging that eyes where you start treatment early and where you do not allow the fluid to stay for longer, over a period of time tend to have a better contrast sensitivity, better outcomes in terms of other visual functions. So I think tackling care of fluid at the earliest and not allowing it to become chronic holds key not only to recovery in terms of the acuity, but also in terms of the quality of vision that's happening there.
Yeah, your question.
Good morning, I'm Dr. Aditi. I have this small question. How do you tackle DMEs in vitrectomized eyes, pseudophakic eyes? That sometimes is a challenge. So what really is your choice of drug in that case?
So at least the half-life studies suggest that anti-VEGFs get washed out much faster in a vitrectomized eye, and therefore one may logically conclude that an Ozurdex implant or dexamethasone implant would offer a more durable effect. The argument against that, especially with regard to brolucizumab, is that, and this is borne out in the real world situation, is that you get visual improvements and you get OCT improvements in 24 to 48 hours. So you are not really now looking at the natural half-life of the drug within the eye, but you're looking at a very rapid penetration into the subretinal space, into the choroidal space, for example, in wet AMD. And therefore, you may have sustained effects even with a drug like brolucizumab, where the half-life may, no longer be relevant.
Thank you. Devendra, that was a nice learning from this particular question, a very nice question. Can I also have a perspective from Dr. Toshinori? She asked about the role of any anti-VEGF versus steroid in a vitrectomized eye having a recurrent edema.
It is believed that clear lines got higher, so anti-VEGF may clear from the vitreous area faster, but VEGF itself is cleared faster. And Dr. Susan Bressler, who was the member of DRCL.net, actually DRCL.net eliminated the chance of vitrectomy for treating diabetic macular edema. But they also reported vitrectomized eyes Anti-VEGF works almost the same. Injection numbers doesn't change. So in Japan also, it is said that vitrectomy causes early clearance, but actually I don't think so. And at least brolucizumab works very well in vitrectomized eyes, I believe. That's my opinion.
Okay. So, Dr. Toshinori also, with his real-world experience, feels that even in a vitrectomized eye having a recurrent macular edema, do definitely well, and they also have a durability almost equivalent to what in a non-vitrectomized eye can be. Your last comment, sir.
I think I absolutely agree. Even before, I think we were not using Ozurdex for every case of vitrectomized eyes. We have used other anti-VEGFs, and especially I would say I have experience with Eylea. It would stay the effect fairly long. So I think it's not. I think we talk all the time sometimes what is applicable in the lab, the half-life or other things, which is not realistic. And with a compound like brolucizumab, I'm sure what Dr. Murata also said, that we're going to have probably an effect for a longer time. So I think we should not go with that idea in mind, which sometimes comes as we evolve over a period of time.
Thank you, Dogra sir. Now let's
Excuse
move
me,
on.
sir. My question is regarding the number of intravitreal injection. In a study, there are 13 to 14 injection, intravitreal injection in a year. Rather, we can go for first the laser, PRP laser. After that, we can become number of injections we are putting in a single eye in a year. It's very much burden on a eye thing.
So your comment, please.
I think what we have to look at, you see, that's why that early intensive treatment is very important. If we do that and we dry it, don't let it come out, then you will not have that many injections. Even in first year, you may have 6 to 7 injections. Second year, I have enough patients. You will just have 4 to 5 injections. By third year, you come already to something like 3 injections. But we have to keep it dry. Don't let it come back. If we follow that strategy, then we are in trouble. Then we'll never get rid of it. Then rather atrophy will also happen. Everything will happen. So as far as you said about the laser and the focal laser, we know it has never reduced number of injections. Maybe little difference it will make, but not a significant one. But we do laser still in many of the cases. So are the trials, which is usually done, say, after about maybe. Most people would prefer after 3 to 6 months, usually 6 months, and you do laser for some of these cases may need less injections, not that they'll totally get rid of it. Yeah.
It also depends on the affordability of the patient. I mean, sometimes the patient cannot afford, so better we go for the.
Yeah, we do respect this particular part. There are two components to it, whether we are treating a macula with a laser or you're talking about a pan-retinal photocoagulation. You're talking about pan-retinal. I think it is prudent that once we have a diffuse type of a macular edema, we do a fluorescent angiography. If you see it is diffuse, naturally the lasers are out for macular reason. And if there are associated peripheral vascular retinopathy, means PDR like components, then of course, yeah, of course you can think about it, adding with it. But if it is not, you don't have a significant new vessels and all those things. Once you start treating with a new rather anti-VEGFs, they do also respond. That is the additional benefit. So you can prevent further visual loss. But as sir has very rightly said, the lasers, except in focal laser, you see a single microaneurysm which is leaking, you treat it, it is fine. But in a diffuse leakage, it is unlikely to be of any help in reducing the number of injections.
Thank you.
Okay. So let's move on to the next talk. Can I request Dr. Debu Chakravarti to have his talk on? It's my privilege to introduce him, Dr. Debdulal Chakravarti, who is a senior consultant at Disha Eye Hospital, Kolkata. He has done his fellowship from the prestigious Shankanetralaya, Chennai, and training in ROP from Orbis. He has been an international observer at Bascom Palmer Eye Institute, Miami, and he has been a reviewer of different medical journals. And he is PI to multiple trials. So over to you, Dr. Dev.
So thank you for the kind and warm introduction, and thank the organizers for this opportunity. So I'll be speaking on new paradigms of DME management, transforming clinical practice. So this is something Dr. Devendra has already so nicely set up, and we are in an epidemic of diabetes, and unfortunately, like he mentioned, it needs repetition that most of these patients are in the working age group. So there's going to be a huge jump of these patients from 537 million in 2021 to 783 million in 2045. So that's a huge jump. And the other problem is it's going to have a huge economic impact. And at this point in time, we have around 75 million Indians affected by diabetes, and it is expected to increase to 124 million by 2045. So that's a huge burden that we are looking at. And of these, 27% of these diabetics have some form of DR, 25% would be NPDR. You will have a DME in 5% and PDR in 1.5% of these situations. So like gentleman just pointed out, you have this thought of multiple injections being necessary for treatment of DME by with ranibizumab or maybe aflibercept. So this is a bone of contention at times. And in India, what the scenario is that you hardly get to give 2 injections or 3 injections over a year in most of these patients. Patients don't agree to many injections. The other problem is they drop out. 66% of DME patients drop out within the first year of treatment. So if you look at the real problems based on a survey conducted and presented at APVRS, so fluid is a problem that is recognized by all of us, and high treatment burden, high cost of treatment, and also high injection frequency is something that all of us retina people and comprehensive ophthalmologists would agree on. So unresolved retinal fluid, it in turn leads to increased injection frequency, resulting higher rates of non-compliance in DME. Now, if you look at various publications, the treatment failure rates can be between 25 and 40% across all agents used. And the Indian DME patient is special in the sense that non-affordability comes as a big problem for us, and most of us have to treat PRN. And there's a low number of injections giving rise to non-improvement of vision, and this is a kind of a vicious cycle that goes on and on. So the need of the hour is increased efficacy, increased durability, and both at a reasonable cost. So brolucizumab may be able to dry the retina better and be more effective in DME, and because of its durability, reduce the injection burden also. So we all know about brolucizumab, and the special thing about brolucizumab is the small molecular size, which can allow pumping in of more molar dose of the drug. So Dr. Devendra has already spoken about kite and kestrel studies, and just to kind of re-emphasize that 70% of brolucizumab patients could be actually successfully managed on Q12 weekly interval in the kestrel and 16 week up to 16 week in the kite studies. And half of these patients actually could have more than these long intervals of treatment. Now, of course, he also mentioned that you need fewer injections with brolucizumab compared to aflibercept. Of course, there was no significant, adverse events in these couple of studies. And if you look at the meta-analysis of publications on brolucizumab, so it is thought of as a drug that has the potential advantage in efficacy and durability over other anti-VEGFs, as we have just noted in the discussion, in treatment of DME and also in diabetic retinopathy as a whole. So we'll just briefly touch about our experience. So this is the first patient actually I treated with brolucizumab. So after having many injections and raised IOP following IVTA, and we offered brolucizumab. And as you can see, after the first injection, there was reduction in the edema, and you can see some intraretinal fluid, some hyperreflective foci here, which is kind of going down after in 2 months' time. This is just one injection, please note. This is after 3 months. So we actually observe these patients every month. And, at 4th month, the fluid was coming back. Sir mentioned that, we shouldn't wait for the fluid to come back. That's a very important point. So you have to find your own sweet spot, so to say, to actually treat these patients and don't repeat, the fluid from coming back. This is another patient, 11 injections of ranibizumab and a very strong family history of glaucoma and fairly controlled diabetes, I would say. We offered aflibercept, but the patient refused because of cost issues. We offered brolucizumab, and this is what happened. So after a month, there was this, area of intraretinal fluid. We just held back, going by our experience. As you can see, at 3 months, actually it has come down from the 1 month, IRF. And this is actually interesting. This is what happened at the 4th month. There was no increase in fluid. And this is, of course, the octa showing, the distorted macula. So you can really have good results in these patients. So this was basically the impetus for a very small publication that we had. Long story short, the key finding was brolucizumab exhibited good visual acuity outcomes lasting up to 16 weeks for treatment of recalcitrant DME. So, what is the story beyond the publication? So, story since then for the first patient is that we've injected 10 injections from 2020 on a PRN basis, and vision is 612. This is just last month. So we also had a similar publication with recalcitrant cases with my friend Ashish, and we actually saw the same story. So initially you have this improvement up to 12 weeks, and then it wanes off. So both with vision and CST, and so like I mentioned, the sweet spot could be around 12 weeks, 13 weeks for many of these patients. So the key points from this study was 2.2 injections roughly over a 6-month period, and most of these patients could achieve 16 weeks treatment-free intervals, and none of these patients reported any ocular adverse events. Now, recently we've published this Brady study, which is brolucizumab versus aflibercept for recalcitrant diabetic macular edema. And we had 30 patients on the brolucizumab side and 28 in the aflibercept group. So if you look at the visual acuity changes, this is something that we had to fight with our ethics committee because there was a significant difference in the visual acuity to start with. The brolucizumab group had worse visual acuity, and this was not actually similar with the aflibercept group. But as you can see, some improvement in these really bad cases following brolucizumab. And of course, one has to remember this is again PR, and so there's some shooting up here. And the CMT changes, as you can see, you have a reduction in both the groups with aflibercept showing a spike here at around 40 weeks. Now, subretinal fluid and intraretinal fluid, similar story. You have significant reduction in both the groups, and brolucizumab group did better compared to aflibercept. And we'll skip this. And the potential, for brolucizumab is there for sustained visual acuity benefits. You have actually 76% patients of DME which were dry following brolucizumab injection in this study, and 50% with the aflibercept. So there was a significant difference of the drying effect with brolucizumab. And of course, we didn't have any IUI. We actually have not had any IUI with brolucizumab in DME. So we've used a fair number of brolucizumab injections. Actually, at Disha, we've used more than 8,500 vials of brolucizumab across indications. And like has been mentioned in the other studies, we had 3.93 injections over a year with brolucizumab compared to 4.75 over 52 weeks with aflibercept. So this is something that works in favor of brolucizumab. So to summarize, with brolucizumab, better anatomical results are possible, better durability is possible. We found it to be safe in Indian eyes, and VRSI has come up with a recent publication of which we are also a part of, which shows a significantly lesser number of IUI in Indian patients. And the findings support brolucizumab as a promising treatment for DME with potential to reduce treatment burden. I'd like to thank you all for your kind attention.
Thank you, Dr. Devdu. Just for the sake, for the information of all the audience here, Dr. Devdu is one of the highest users of brolucizumab across the indications in our country. Probably his numbers are much more than the kite and Kestrel studies individually per indication, I believe. So how much is the experience with you for diabetic macular edema? How many injections?
Sir, thank you for those comments. But actually, at Disha, we see 15 lakh patients in a year, and we have 27 odd retina guys. So it's a combined effort, not my effort only.
No, I'm not trying to compliment. I'm just coming to it that we have an experience bigger than what the kite and Kestrel we quote whenever we talk about IO and the fear of using this molecule. That's why I'm trying to tell the magnitude of the in this indication. Yeah,
sir, we've at this point in time, the patients out of these 8,500 vials, we've had around 55 to 60 cases of IOI. None of them had needed vitrectomy. One patient actually, in the very initial phases, there was a patient who actually was injected dexamethasone. But subsequently, we've been using only topical steroids. Some of these patients who are non-diabetics, we've obviously, because these are NAMD cases, all of these are NAMD cases, we've used oral steroids if we thought, but now it's mostly topical steroids. And for the last 6-7 months, I don't know why, and this has been something that I have come to know from some other friends also, we've had no IOI, touch wood. We've had no IOI for last 6-7 months. So I think something good is in the offing.
Number of injections out of the number of for diabetic macular edema you have treated approximately.
Sir, it will be more than 2,000 vials.
2000.
Sir.
So for the sake of viewers here, just observe all the audience. The overall cohort or the study group of kite and kestrel might be 300 plus cases in kite and
Absolutely, sir. More than that, much more than that.
And that was initial 2 years. With this such a volume, I think the fears which were expressed needs to be negated, and this molecule which can definitely help our country, where as the respectable sir from the audience pointed out that the number of injections which we need is going to be a burden and most of our patients can't afford it. We have a solution to it. Sir, Dogra sir, your comments.
I absolutely agree. I think we can have a little more discussion maybe after the last talk, because we're going to have other experience also, and that will be the right way to go. Perhaps that's what.
So thank you, Devu. Please, can we have the next speaker? The next speaker is Dr. Toshinori Murata. He's a professor at Shinshu University. He has graduated from Kyushu University School of Medicine, Japan in 86. 96, he was a research associate at Doheny Eye Institute. Then 1998, he was a research fellow at Harvard Medical School, Boston, Massachusetts. 2004, he became an assistant professor at Department of Ophthalmology, Kyushu University. And currently, he is professor and chairman of Department of Ophthalmology, Shinshu University of Medicine, Japan. And also, he was a president of Japanese Ophthalmic Society from year 1919 to 2022. So it's our privilege to have you, sir. Welcome. Welcome to our country.
Okay, thank you for kind introduction, and it's my honor to be here to give this presentation. I'm going to talk about diabetic macular edema with treatment with brolucizumab. I think we have almost 3-year experience, and this is my COI. So for second generation new anti-VEGF agents should have strong efficacy, achieving early vision recovery after 1 or 2 injections. That's ideal. A longer interval durability, making eventual discontinuation of anti-VEGF injections. Otherwise, it's very expensive treatment, so patients cannot afford. So, yeah. Preserved ellipsoid zone indicates intact photoreceptors, and if we start brolucizumab injections at this time point, it almost always results in very good vision. It should be 6/6, I think. And on the other hand, if in the chronic macular edema, ellipsoid zone photoreceptors are already lost. So even if the brolucizumab make macular edema resolution, it does not result in vision improvement. So the effect of RA treatment has proven by Protocol V. They treated within 4 months after the vision deterioration due to diabetic macular edema. An average visual acuity of 20/20 was achieved in their study. So next step is macular edema resolution and vision recovery after 1 or 2 injections. So we wonder why. Why are 3 to 5 monthly injections, meaning induction phase, are always included at the beginning of protocols of phase 3 clinical trial in diabetic macular edema? It was with first generation anti-VEGF, and until it falls below the cutoff value threshold, a reduction of central macular thickness does not lead to vision improvement. But once it goes below the threshold, dry macula is achieved and vision got improved suddenly. And with brolucizumab, we don't need 3 to 5 injections. So let me show you a patient. Vision got improved after single injection. In this patient, a brolucizumab was injected, and 6 weeks later, the vision is already 20/20, and there is dry macula. And I think you talked about panretinal photocoagulation. I think it helps. I will explain it later. And you may think this is very, very exceptional case, but we experience many cases like this. And it has been proven in phase 3 study, KITE study, aflibercept was used as control drug, and 4 weeks it reduced maybe this number. And brolucizumab, it has longer duration of interval, and 6 weeks later, CMT gets much thinner. So this is from Kestrel's study we belonged. We belonged to Kestrel, another phase 3 study, and among Japanese population, the baseline was 437 micrometer, and just single injection of brolucizumab reduced its 125 in average. So simple calculation, based on simple calculation, a single brolucizumab injection may reduce central macular thickness to below 320 on average, which is the threshold for macular edema that may result in vision improvement. I know this is too simple calculation, but there is possibility. In Japan also, because of the concern for IOI, the market share of brolucizumab almost reached 0 as Western countries, but it came back now. It's 20%, and for PCV, it's almost 30%. And this explains why. Among Japanese population, brolucizumab-treated eyes shows the early edema reduction effect, which was pronounced in Japanese population, while it was not prominent in overall population. That means Western countries, I think. And we are allowed, there are so many regulations and restrictions, so we are not allowed to see or touch the data from other Asian countries, but I believe it happens among Asian countries. And this is a case from phase 3 study. In this case, a single injection resulted in 20/20 vision, and fluorescein angiography shows marked reduction of leakage. An average injection of Kestrel study was 11, so he underwent 11 injections, and vision was 20/20. And there have been no recurrence of diabetic macular edema for 3 years and 7 months, so it appears 7 brolucizumab injection led to complete cure, no further injections. We are not the only ones who thought that brolucizumab can make discontinuation of injections possible. Surprisingly, from Western group, they reported 3 out of 4 patients did not show recurrence of diabetic macular edema after phase 3 study. And they also suggested a dry macula obtained by brolucizumab. Its drying effect was correlated with subsequent discontinuation of anti-VEGF injections. And we conducted a doctor-initiated study to investigate this hypothesis among Japanese patients. And this is the most important slide. This shows many regulations prevented us to touch or see the data from all patients. We could see the only 19 cases we ourselves treated, and 15 out of 19 cases were followed up more than 3 years or longer after the conclusion of Kestrel study. So among those 15 patients, 8 successfully discontinued injection. And when we focus on brolucizumab, 9 out of 10, so it's about 70%. And the report from Europe was 3 out of 4, so it's 75. Both studies have a limited number of patients, but I want to say it's highly likely 70% of patients can discontinue. So we wanted to find out what factors made the discontinuation possible. Then we investigated the correlation between the duration of dry macula and subsequent discontinuation of anti-VEGF injections. There are 2 types of dry macular duration. One is continuous. So the longest continuous dry macula was 3 months for this for this setting or for this patient. But the total duration of individual dry periods is 11 months, and we hoped 11 months works. But unfortunately, duration of only continuously dry macula was correlated with subsequent discontinuation of anti-VEGF injections. Total duration did not have effect. So the next question, the dry macular period needs to be continuous. So the next question is, how long do we have to maintain dry macula continuously? So we used first logistic regression, and the number is small, so we cannot say definite things. But when we set central macular thickness, 270, it's 5.77 months. So it's about 6 months. So if we divide 24 weeks, so it divide by 6, it's 4. So 5 injections may lead to discontinuation in 50% of cases. And the central macular thickness is thicker, it's easier. So until 290, we had found correlation between continuously dry macula and discontinuation. So let me show you a real-world case. This case motivated us to perform that kind of study. In this eye, we injected aflibercept. In Japan, I have to say aflibercept used to be or still is the first choice. And after 1 month, we did not see much difference, thickness, vision, and the area. So we switched to faricimab. It was available in those days already, and it showed a little improvement, white area over 500 diminished in size. So we injected one more time, but we didn't see much difference. And at that time, brolucizumab became available, so we injected, and in 1 injection, vision got improved, and after 2 injections, almost resolution of diabetic macular edema was achieved. What do I do? I was told 15 minutes talk, so I prepared. Can I go on? Okay, so allow me to go on. So it's 2020, so just 2 brolucizumab injections resulted in vision recovery to 2020 after switching from aflibercept and faricimab. So we kept injections, and the interval got 3 months, then it's 6 months. So we didn't put cap of 4 months. We extended as much as it's possible. And 6 months after, it's still 2020, and there is tiny cystoid macular edema. We suggested injections, and patients agreed. She was happy with this vision. And the other eye, the vision was very, very poor. So we injected 6 times, and now it's 7 months. And this is my personal impression, but if we could repeat 6 months interval 2 or 3 times, it reaches total discontinuation. So far, as of today, 20 months, no injections. So we believe 7 brolucizumab injections have made to discontinuation of anti-VEGF injections possible. And in this case, again, this patient has widespread non-perfusion areas. So to prevent proliferative stage to progressing to proliferative stage, we needed pan-retinal photocoagulation, and for macular edema, we injected brolucizumab. And 5 injections in total maintained dry macula for 21 months. And now no additional injection for more than 2 years after this. I used to be a basic researcher, as the doctor said. I went to Harvard and Los Angeles. An injection of VEGF itself, bad guy, into the vitreous of normal monkey eye, it induced microaneurysm formation and macular edema in the macula, microaneurysms and leakage in late phase. So VEGF from the peripheral retina also causes diabetic macular edema. So in this eye, VEGF from local macular ischemic cells exist, and it causes diabetic macular edema. But there are many more ischemic cells in the periphery, and VEGF can be secreted from the cells, and it is water soluble, so it can go anywhere. When it goes to trabecular meshwork, it causes neovascular glaucoma. So all VEGF can come to macula. And if we were treated with injection only, macula is only 2% of the entire retina. So anti-VEGF injected will be wasted 98% for suppressing VEGF from the peripheral cells. So maybe only one suppress VEGF from the macula. But if we perform pan-retinal photocoagulation to prevent progression to proliferative stage, ischemic cells in the peripheral retina are eliminated. So all injected anti-VEGF can be used to suppress VEGF produced in the macula. So we can enjoy longer duration, longer injection interval, and more higher possibility of discontinuation of the treatment. This is my personal opinion. So an injection regimen should be designed to keep the macula continuously dry to facilitate the subsequent discontinuation of anti-VEGF injection. Thank you for your attention.
Thank you, Professor, for wonderfully eliciting the importance of this particular molecule. Please do join us for the discussion. Let's initiate the discussion. You seem to you have a longer experience with the faricimab in management of any diseases compared to we Indians. So how do you look at comparing head-on the faricimab versus brolucizumab in treatment of diabetic macular edema?
Thank you for the question. It may be difficult to answer that question here, but brolucizumab is the only one drug we believe that is better than Eylea 2 milligram. Faricimab and Eylea 8 milligram is not that different from Eylea 2 milligram. That's our impression. So in the future, if Eylea BS biosimilar prevails, I think the only drug that will overcome that wave is brolucizumab, I think.
Okay. So you, please.
I think what he has shown is very important. We must remember, if we have that sawtooth kind of a thing happening, then we are probably giving injection for longer time as well as having poorer outcome. And what he showed was the straight line, like that means he was showing that he was not letting that sawtooth come back with brolucizumab. And that is what is very important. And that's how probably 50% of them, they were off any treatment for a very long time. I think that is what we have to aim for. And he also mentioned about what the gentleman here asked earlier also, that this ischemic retina in the periphery. These days, even many people, they give anti-VEGF when before they perform PRP. And he showed that leakage and that ischemic area in the periphery is also contributing. So I think if that strategy is also followed, it helps. But this is very impressive. If we have something, we don't let it become sawtooth. I think that is the bottom line, according to me, which we have very nicely shown.
If you look at it, in terms of the fluid drying capacity, I think brolucizumab is an extremely superior molecule. We have had cases where we have given brolucizumab and the next day itself there has been a significant reduction in the macular edema. So I think one of the biggest advantages that brolucizumab affords to us is a much superior fluid drying capacity. And now that our experience with brolucizumab is growing, we are also noticing the effect or the efficiency of brolucizumab in terms of the sustainability of treatment. So increasing the treatment interval is also becoming more and more important. We are now increasingly seeing patients who are being maintained at 12 weekly, sometimes even 16 weekly interval between two subsequent injections. So extensive fluid drying, very quick effect, and now in some of our cases even a sustainability of the duration and a longer interval between injections. So a lot of advantages which we are now seeing with these molecules.
Mudit, we are talking about increasing the duration between the injection. But professor also showed it is possible for us to discontinue the treatment and
Totally.
have a disease free. What's
Exactly.
your experience of your institute?
So we have had a few patients. Our experience is not as extensive in terms of the duration of follow-up of more than 1 year to 2 years. We have had, I think, the largest follow-up that we may have had has been around 3 to 3.5 years for some of our patients. But what we have seen is that a few of them now we have been able to completely wean off from injections. Though to be honest, that does come with other anti-VEGFs also over a longer period of time. Like what professor showed, there are some patients who are responding within 1 to 2 injections completely and are maintaining that for a longer duration. We had one patient, one-eyed school teacher, the other eye lost to macular ischemia, had received multiple Ozudex earlier, had also received different anti-VEGFs, got 2 injections. After that, for nearly 3 to 4 months, absolutely no recurrence. Actually, he had a bit of an anterior segment inflammation after the third injection, but this is the only injection that worked for her. And she herself said that if possible, give me the same injection again. The inflammation, though minor, and that is one of the biggest fears people have had with brolucizumab, but like what Dr. Devdulal had also shown, now either because of better case selection or because we have become more vigilant, or for some other reasons which we can't explain in terms of antigenicity, the number of adverse events has gone down significantly. So this patient got the third injection, then the fourth one, and now after for now more than 18 months, she is maintaining a visual acuity of 20/25 without the need of a single injection.
Devdulal, for you, the question goes here. Have you seen cases? It's like a dream come true for me that we will have at least a subset of patients who can be injection free.
Absolutely. This is a DME session. I was just talking to Dr. Devendra regarding many of our patients with NAMD not needing treatment for 6, 7, 8 months. So maybe even 1 year, couple of patients for a year. So, this is something that is actually a reality. And as Professor has shown, we actually need to think, Sir has also mentioned that we actually need to think of, getting these patients off treatment rather than injecting periodically.
Yeah, Devendra, you want to make a comment?
Yeah, just a quick comment. We were talking about the longevity and the maintaining the retina dry. I think it's more important in DME than in NEMD, because there the culprit is subretinal and it's leaking into the subretinal space and intraretinal fluid. Here it's the blood retinal barrier itself that's at fault. So it's not just the vascular component in the retina, it's also the neuronal damage that is going on. So this longevity of effect is particularly important for better visual outcome in DME than it would be in other diseases.
So as it happened with other anti-VEGF molecules also, when any new anti-VEGF molecules come into the play, initially we do have some immunogenic responses, and as the time fades, we overcome, we have a better batches, and that has been a history for all the anti-VEGF molecules. Initially there were a few cases, and now if you look at the real world experience of any molecule, you would see that IOIs have come down, the inflammations have come down over a period of time. And luckily for us, for this molecule which is giving us such a possible dream of having a disease free or an injection free disease, also having better durability, I think it is going to be a big boon to us. Can I have a comment from Dogra sir regarding this particular aspect of it? Is he really afraid now to treat just because, or holding back because of the fear of inflammation for such a beautiful molecule, but for that?
I think somehow I also feel for DME cases, we have seen hardly, very little of even reaction, whether it is to do with what we are talking, using it for longer time. But that is what is a reality. We also use much more, I would say, at least in my center, more for DME than for AMD as far as brolucizumab is concerned. So what we have seen two scenarios. Also what in fact has been shown in various cases. One is that one injection dries it totally, and it is absolutely dry. Can we have a protocol on that with one injection, then the second one, when it is just trying to come back or a little bit, we give that time. We don't let it come back. And then there's another scenario where it doesn't dry with one injection. There we have to give multiple injection, perhaps what has been done by Dr. Maratha also, and make it dry. I think the question is drying. this macula. That's how we'll get probably injection free over a period of time. Because if we allow that to come back and have a sawtooth, then we will never. I'm very impressed with that part of his graph, and that is something which is excellent, because sawtooth is not a good strategy in any treatment ever, so that we have seen in past. I think if we can have a protocol somehow set for these two things, once where it is drying completely with injection, one injection, in other it is not, I think it will go a long way. But it is a great compound, it is going to stay there. And for DME, at least we have also not seen. All the reactions we had were also in cases of exudative AMD.
Sir, if I can ask you, then what would be your follow-up schedule of a dry macula?
You see, that's what I want to say, that here you can call them back as it's known that this is last longer. Maybe you can call them at 6 weeks. And if it is still totally dry, you give another time. But I don't want it to become sawtooth. If you give before that, and then perhaps if we continue on that, maybe it is 3 monthly, or maybe 8, some of them 2 monthly. Maybe we get rid of in 6-7 injection, as the cases are already shown here by Professor to us, which is a great education, I must say. Yes.
So for the sake of audience, I think we should then, we are coming to a consensus that yes, this is a molecule of choice even for a diabetic macular edema. We can bring down the edema, and once the edema is bare, we can have a disease-free interval for a longer time, or sometimes a disease-free patient for that particular case. So can I ask Professor, what is his protocol about how he initiates his treatment? Does he have a loading dose protocol for this? And then how does he follow up? Means will it be 6 weekly follow up or 8 weekly follow up, or what is the protocol you do for a diabetic macular edema case?
For diabetic macular, thank you for your question. For diabetic macular edema, we inject once as soon as possible after vision deterioration, and it covers 6 weeks usually, brolucizumab. So 2 injections covers 3 months. And during that time, we perform pan-retinal photocoagulation if it's needed. And usually pan-retinal photocoagulation induces diffuse macular edema. But with the help of brolucizumab, it doesn't happen. It reduces. And after that, we kind of treat and extend. Each patient has his or her own fixed timing to recur. So we find it, and then we follow up with that interval and gradually extend it by 1 month.
Great. So you mean you inject first injection, 6 weeks later you give a second loading dose, and then following after 3 months it's a treat and extend.
Yeah,
exactly.
it's treat and extend.
Okay.
Yeah, yes.
So Dr. Devdulal, Dr. Devendra, and last we will have a comment from Dr. Mangat Dogra. How is your treatment protocol for diabetic macular edema, whether you believe in loading dose or you follow the principle how Professor Toshinori is suggesting?
We don't give loading dose with DME. We actually call these patients back every month, initially when we put them on any drug for that matter, and then we follow up.
So right from that, after first injection, it is PRN. Absolutely. Devin?
Yeah, I would tend to agree with that. PRN in the sense that at least 3 months of a monthly follow-up, and then subsequently we can attempt to extend.
Okay. And for you, sir?
Well, if we talk of other anti-VEGFs, we believe strongly in loading dose, because that is early intensive treatment. But here it is a strong molecule which is drying it up fast and doing probably what we achieve with multiple injections. Otherwise, early intensive treatment for anything is very important. But here we do the same thing. We call after 6 weeks, as Dr. Mrata said, and most of the time we have not repeated before 6 weeks. We have usually done after 2 months with brolucizumab, because we have not given loading doses with brolucizumab. That is what. But at the same time, I think we have to find out our that range where we can sort of keep it like a loading dose concept only, not a PRN concept. Yes.
So I think if I sum it up rightly for the sake of audience, everyone agrees that we inject early once we have a diabetic macular edema. even in cases of diabetic macular edema, we should be initiating, we can initiate the treatment, be it a naive, be it a recalcitrant case with a brolucizumab. Then we see 4 to 6 weekly, but no need of any injections before 6 weeks because it's a stronger molecule, as Professor Dogra has said. And after that, then it becomes more of a PRN basis. But sir, if I ask you one more question, the edema was say something around 600. It has come down to say around 300, 450. When will you inject? Because you don't want a seesaw.
No, that's what I'm doing. What I have done in some of these cases, they were previously also on other drugs, including Ozurdex, Eylea, everything they have received. And I have this one gentleman, he's receiving in both eyes. And I have found out also the period before when it is going to come. It is not coming before like 2.5 months for him. So we have to find out that period, and that is where we are injecting. And I'm sure now it is going to increase, and maybe, as Professor Radha said, we'll get rid of the injection down the line. So what is important is, I think you'll have to find out. If suppose it has come down to half what you said, I have injected at 6 weeks, second injection. So that is very important. You want to dry it out. Don't let it be there. That is very important. That is essential. Yes.
So I think we are just at the conclusion of it because of want of time. I would just sum it up for the sake of all audience. You get a case of a diabetic macular edema, please do not hesitate to use this wonderful wonder drug. Rather, I should cause, if I can say so, because it causes a wonderful drying. In almost majority of the patient, you get, especially the naive ones, you get a significant drying with a single injection. And if you get the single drying, you can afford to see this patient somewhere around 6 to 8 weeks. And if the edema is on a declining trend, less than 300 or 3, you don't need to inject, and then you wait for the edema to come back and then you treat it, something PRN. In event, if you are treated, it has moved from 600 to 400, you can give a second loading dose, say around 6 weeks later, not earlier than that. That is what I think most of us need to understand, because this is a very stronger molecule, and so you have to use it rationally and not overload it so that it causes an IOI or some sort of inflammation. So I think any questions from the audience, if anyone is interested in having, especially for Professor Murata, who has flown down from Japan. Okay, that's good. So I think thank you everyone for attending this wonderful session. Thank you Novartis for having this particular session. We all agree that this is a wonderful molecule. It causes a instant drying, rather I should say, a durable drying, and the fear of IOI, which was expressed in initial studies, has been negated in a lot by real world experience, be it our Indian own studies or the studies abroad. So you can definitely use, and you should be using and passing on the benefit of this stronger molecule, which can give you a dream of disease-free eye, for our own patients. Thank you. Thank you once more. Thank you, Professor Murata, Dogra sir, Dr. Devendra, and Dr. Devdu. Thank you. Can we have a group photo? No, what is it?